Today I'm going to talk about neurological implications of PHACE syndrome. And I know everyone knows this and you've had it, gone over it every single day since you've been here, but P for posterior fossa abnormalities, H hemangiomas, A arterial anomalies, C cardiac abnormalities, and E abnormal abnormalities of the eyes. I'm going to focus just on the P part, the posterior fossa, and brain abnormalities. And before I start talking about that, I just wanted to talk about what a peds neurologist, what we look for and what we see in patients. Patients are sent to us if there's any abnormalities or problems with the brain. So this could be infections in the brain, trauma, or cortical malformations as the brain is developing. If the brain develops abnormally with too much tissue or stops in development and there's places that are absent. We also look at spinal cord. So the brain can be totally fine, but if there's problems in the spinal cord, and the cord can have infections there, trauma there, and we'll see patients with that problem as well. And from the brain, messages are sent through the spinal cord to the nerves. So if there are problems, patients that have nerve problems, we see those patients too. And it could be an isolated nerve problem, compression, virus affecting the nerves, or trauma to the nerves as well, inflammation to the nerves. And lastly, if it's problems in the muscle itself. So patients who have muscular dystrophy or isolated muscular problems. So if a patient comes into clinic and they have weakness, the job of the neurologist is to figure out, is it a muscle problem, is it a nerve problem, is it from the spinal cord, or is it from the central nervous system, the brain. Also, a lot of patients are referred to us that will have normal looking brains on imaging, but they'll have developmental delay. So we'll do genetic testing or metabolic testing to see what's causing the delay. Some of the metabolic testing is how you break down fatty acids in your body. So a lot of blood work and labs to find out those areas. Other than looking at each part, patients with movement disorders, epilepsy are a big part of our patient population as well. So back to the face, the P, the posterior fossa. And before, in the first diagram here, you can see how the brain is divided into lobes. There's the frontal lobe, temporal lobe, parietal, and occipital. And each part serves more than one purpose, but there's functioning areas in each area. So movement, our motor strip is in one area. Occipital lobe is mostly our visual area. And then the brain is, we look at it as the right hemisphere and the left hemisphere. So the left part of the brain controls the right part of the body and vice versa. Now when we look at the posterior fossa, it's this area in the back, and we have here you can see the cerebellum and the brainstem. So a lot of the patients we see will have, in PHACE, will have posterior fossa abnormalities. So that means if the cerebellum is affected, the cerebellum is an area that regulates balance and movement, coordination, so they might have difficulties in this area. The brainstem, we have a lot of the cranial nerves come from the brainstem, and so eye movements, swallowing, respiration, all can be controlled in that area. And you can have one problem, not all of them, but you can have isolated areas in the brainstem that are affected. So when we talk about cerebellar abnormalities, and you look up PHACE syndrome, you often see Dandy-Walker complex come up, cerebellar hypoplasia or atrophy, and that means when the cerebellum was forming for the hypoplasia, it just didn't form completely. There's one part that was absent or smaller or irregular. You can also have migrational abnormalities with polymicrogyria, microcephaly, or heterotopia, and I can go into more detail with those as well. So going to Dandy-Walker complex, a lot of things are called Dandy-Walker complex, but what they're looking at is if the cerebellum is formed or poorly developed, and you have an enlarged fourth ventricle. So on the left side, you have a normal head CT, and these are the ventricles where the cerebrospinal fluid, everyone has that, we all have that. And on the right, you see that this part, and here is the cerebellum. And here on this side, you can see that it's very much smaller, and you have a lot more fluid. The black area is all fluid. So when you talk about hydrocephalus, that means increased fluid, that's seen, and then the cerebellum here is much smaller on the right. And here's just another view, like Dr. Johnson was talking about, different views of the brain. Here you can see the cerebellum here, and this is the brain stem. And on this side, the cerebellum is much smaller. You have a lot more fluid. And this is the ventricle. This is the normal size here. And this is much more expanded. So that's what, and this isn't a PHACE patient, by the way, but it's what you would see with Dandy-Walker complex. So clinically, when you have a patient with these findings, you won't see all of these things, but you might have poor balance in children, poor fine motor movements, developmental delay, and that's really variable. You can have significant delay or just a little bit of delay in school. 15 to 30% will have seizures and often will need to be on medication. Poor vision, and like I talked about, hydrocephalus. I talked about migrational disorders. As the brain is developing around 20 weeks of gestation, the brain cells or neurons sort of move from the middle part of the brain and they're traveling outward to create the cortex of the brain. And during that time, if there's any disruption or arrest, the area in the brain can become larger or areas develop abnormally, and that's where you have a migrational disorder. So if you have, I talked about heterotopia, polymicrogyria, all those are malformations that develop as the neurons are moving out and they stop in the wrong place. And there's an area that's thicker or thinner in the brain. When you have that, you have a number of symptoms. You can have seizures. Once again, some are easier to control with medication and some more difficult. Developmental delay, and that's sort of a term, once again, large range. Motor deficits, language deficits. Other abnormalities that we can see, even without specific changes on the MRI or in the brain, you can see headaches, strokes, and seizures. So migraines are pretty common in children with PHACE, but they follow typically with migraines that other children have. And usually the children will complain of headaches on one side. It's sort of throbbing. Associated, the light usually bothers their eyes. They want to be in a dark room. Sounds can bother them. Oftentimes they're nauseous. They feel like they might throw up. And sometimes associated with you can have weakness too. And that's a complicated migraine. And with PHACE patients, you worry more, is that a stroke or is it just part of the migraine? And as they get older, sometimes they can get more frequent as well. Now, the first type of treatments that when we see children with any type of migraine, whether it's PHACE patients or just patients that come into clinic with migraine, we try to do lifestyle modifications. Things that really help with migraines are sleeping. Like kids will go to a sleepover, they'll come the next day, and kids who have migraines will have a worse migraine because they didn't sleep. So we say at least 9 to 10 hours of sleep daily. And staying well hydrated. Kids we usually say about 8 for 7-year-olds and higher, 8 glasses of water or Gatorade daily to keep really hydrated. And avoiding foods. I never thought this was that important, but foods really play a role in migraines too. Foods with NutraSweet can really make migraines worse. Sometimes chocolate, and when kids hear that, they're like, that's not gonna happen. But you gotta test it and see. For some kids, chocolate acts as a trigger. Aged cheeses, which kids usually don't like anyways. But the big culprits are NutraSweet nitrates. And nitrates can be in like smoked meats and things like that, can make migraines worse. And not skipping meals. As they get older, especially teenage girls will skip breakfast or skip meals, and we always say have the 3 meals with snacks. And trying those lifestyle modifications can really help with the migraines. So before putting them on medications, we try that. And once that's done and the migraines still persist, if it's disrupting their going to school or if it's happening a couple times a week, then we think about medications that could help. And the medications we use are prophylactic medications that they can use on a daily basis, and usually treat them for about 6 months. And if it's really working, then try to taper them off and see how they're doing. Abortive therapy isn't really used for PHACE patients because sometimes it can cause problems with the vessels, and so you want to stay away from that in patients with PHACE.
What is that? Yeah. What kind of therapy?
Like triptans, Imitrex, they call them abortive therapies. So nasal sprays, Imitrex, triptans, anything in the triptan family. All right. Next, quickly about stroke. A stroke is a lack of blood flow to the brain, or in areas of the brain. And this is like, I know you saw the really intricate pictures, but to call it a stroke, we usually say a deficit lasting for greater than or up to 24 hours. And there's something called transient ischemic attacks when they're very brief and they resolve completely. There's 2 types of strokes we see, especially in the pediatric population. We can sometimes see hemorrhagic strokes where there's blood that's leaking into the brain tissue. And an ischemic stroke, where a clot forms, so the blood is forming, for some reason there's a clot there, and the area that's supplied doesn't have the blood flow, so it will not function properly. And the symptoms we see, the symptoms we see are based on where the dysfunction is. So if it's in the motor area, you're going to have weakness. If it's in the language area, you might have difficulties with speech. Now, incidence of stroke in children less than 15 years of age around the world is about 6 cases in 100,000 per year. And it's most likely related to rupture or changes in the blood vessels, narrowing, and blocking the passage of blood. But a lot of children will have changes in the blood flow because of the vessels, but also different problems with the way they clot blood too. And that can, both factors together could play a role in stroke itself. The symptoms that as I was talking about, in adults we usually see more weakness, motor loss, but in kids it can sometimes be difficult to see that right away. They could be just a little bit, not themselves, not as responsive, sometimes more irritable. A lot of children will also present with a seizure, and the seizure will occur in the area or is a result of the lack of blood flow in that area. So if it's the first time seizure, you want to worry about or be concerned about that as well. And once again, the function, the abnormality or the area that the stroke is taking place, that's the kind of function deficit you'll see. So if it's on the left side of the brain where it controls arm movement, you'll have right-sided weakness. If it's in the area of speech, then you'll have, they might present with difficulties initiating or speaking. Next thing I wanted to talk about are seizures. Seizures are when the brain cells or the neurons fire abnormally. And this can be caused by structural abnormalities in the brain, but it can also be, patients will come in with seizures and we look for a cause and we can't often find them. But like I mentioned previously, it's also sometimes the first sign of a stroke as well. When you have recurrent unprovoked seizures, and what I mean by unprovoked, a lot of children will have seizures when they're babies, even under 5, with fever, and they can be related, they're febrile seizures, and you don't often put them on medication. When they're unprovoked, when it's not due to an infection, and we look for causes, and they continue to have seizures, that's when we call it epilepsy. So when you see seizures in PHACE syndrome, it's often related to migrational disorders, as I talked about, strokes, or Dandy Walker malformation can be a cause for it as well. Now, if children have seizures, one of the studies we do is an EEG where you put the electrodes on the head. And this is probably more electrodes than a child will get, but I wanted to show how it's pasted on. And what happens is each electrode will tell us the function of that area in the brain underneath the electrode. So here's an EEG tracing, and the odd numbers, the numbers are listed here. Odd numbers are from the left side of the brain. The even numbers are from the right side. And the F for the frontal, T for the temporal, O for the occipital, C for the central, so we know where it's coming from. And on this EEG, you can see that this looks a lot sharper, more chaotic than this side. So this is an example of a seizure coming from the left parietal region. So, of course, you can see the seizure in the child while they're having this, but it's important to know where it's coming from and how it develops so we can pick the right medicine to treat it. So there's different types of seizures. When you think of seizures, you often think of falling to the ground, shaking, losing consciousness, eyes rolling up. But you can have a seizure, a partial seizure, where your consciousness is, you remain fully aware and your consciousness is preserved. So once again, going back to the left side of the brain, right side of the brain, if I was having a seizure isolated to the left side of my brain, I could be awake talking to you, and my right arm could be moving, and that would be a seizure. Once that spreads to the whole part of the brain, that's when I would lose consciousness. So then I could start like this, I could fall to the ground, and then become unresponsive. So we think of it as, there are more categories, but partial, meaning from one side, or generalized, where the whole brain is involved. So this, once again, is a picture of that, where this is the cortex of the brain. There's something called the motor strip and the sensory strip. So if a seizure is taking place there, the patient might just feel tingling or sensory changes on one side of the body. If this picture, the eyes are deviated to one side, the arm is going up, the head is going to one side, that means the seizure is coming from the opposite side of the brain, causing the body to do that. So it's important to know what kind, once again, so we can put them on the right medications. You can also have something called Todd's paralysis after the seizure. So it might seem like a stroke, where they have weakness, and it can be several hours to even a couple of days at max, where they're weak after the seizure, and you don't want to think that was a stroke. So imaging should be done to make sure that, was it a stroke or was it a seizure with paralysis that will resolve. So treatment for epilepsy are different types of medications. There's many different types, and based on the type of seizure, we pick the right medication for that. And for intractable patients, and meaning going through many different types of medications and still having seizures, we look at surgery 2 times for treatment and management. So basically, I just wanted to give an overview that in PHACE syndrome, although we think of the P part just to affect the posterior fossa, there's different elements that we need to look at. And that sometimes further testing, I know we do so much testing already with MRIs, but sometimes we have to do a few other things if they have seizures or headaches and things like that. It's just to keep those in mind. That's it. Thanks.